OPB Podcasts.
From the Gert Boyle studio, it's OPB Politics Now for Thursday, July 9th. 1 year ago this week, President Trump signed his so-called One Big Beautiful Bill into law. We knew then that major changes were coming for Oregonians who depend on the state for health care coverage. Now we're learning a lot more about what the federal cuts might mean for the Oregon health plan. This week, we're going to talk about what we know and what we don't about how Oregon might proceed. Welcome to the podcast. I'm OPB politics reporter Dirk Vanderhart.
And I'm OPB health reporter Amelia Templeton.
Amelia, it is always fantastic to have you on the podcast, especially so I would say this week, because you more than anyone else at OPB have been digging into what I think is going to be one of the biggest policy puzzles state leaders are going to face next year, but probably over the coming 5 years or something. It has to do with a massive and growing funding hole Oregon expects for its version of Medicaid, the Oregon Health Plan. I want to just start out with the most immediate number. How much are officials expecting they'll be short in the next 2-year budget to pay for health care?
So in the upcoming biennium, the state would take $421 million more than the state has to continue the Medicaid program as it is today. So that essentially means they need to cut $420 million in spending or somehow come up with the money.
And it can be hard, I think, to keep numbers in perspective sometimes with budgets. You're throwing out billions of dollars. I mean, I would just say as someone who covers budgets, this probably won't surprise anyone, but $420 million is real money, meaningful money that will be hard to find, as we'll get to.
That's right. It's about 5% of the state's total Medicaid budget through the Oregon Health Authority.
Wow.
So, it's not an impossible number, but you're talking about, like you said, a meaningful cut.
Yeah. I think we talked a ton about H.R. 1, that so-called Big Beautiful Bill, in the months after it was passed. We've probably talked about it a lot this year, and I'm just forgetting. But I will admit to you right now, I think I've forgotten many of the details surrounding how it was interacting with healthcare, like why it was going to create these difficulties. But this bill is a big piece of why we're staring down this shortfall.
Yeah, so H.R. 1 is absolutely a big part of this shortfall. I think before we get to the bill, there is just a little bit of stepping back that I need to do. So Oregon's Medicaid program has been getting more expensive. The cost of the program has been growing faster than the state's general fund revenue for a number of years. And there are some fairly, I think, straightforward reasons for that. The prices for everything in healthcare, hospital care, prescription drugs have been going up quickly. And we've also seen the state legislature expand what the program offers. So, particularly around behavioral health, mental illness, substance use disorder, we're offering, I think, more and more expensive services than we used to. All of that's been adding to the cost of this program.
Yep.
Then you have last year, just about exactly a year ago, Congress passing the largest ever cuts to Medicaid in the history of the program, cuts that are affecting every single state across the country. If you want to get into the nitty-gritty of how it works, there's actually a big change in H.R. 1 that's going to save the state a bunch of money, and that is it imposes a work requirement on a certain subset of the Medicaid population, and that the state estimates is going to cause a ton of people to drop out of this program and lose their health insurance. And that saves the state a considerable amount of money. Okay. But those savings are offset by the fact that this bill makes it much harder for Oregon to qualify for federal funding, federal matching dollars, through some limits it imposes on things called a provider tax and state-directed payments. Basically, those are ways that the state has been able to sort of borrow money from hospitals and health systems, qualify for federal dollars, and then use that federal funding to return money to hospitals and health systems in the form of payment for the care they provide to people on Medicaid.
You and me were looking over a diagram about all this beforehand, and it got very, very technical. I mean, what I took from it, and this is just very lay, like half understanding it, you're right. Like, we're saving a bunch of money because fewer people will be on, but there are all these reasons under HR 1 that costs are going to increase. And that gets to this hole where I know that's a gross oversimplification.
No, that's pretty good. I think there's there's two final wrinkles that I think are interesting enough to mention. And one is that the bill also directly cuts the reimbursement that hospitals get, that the state gets, for emergency care for undocumented immigrants. So hospitals are required by federal law to treat anybody, to stabilize anybody who walks through their door. And that, doesn't matter what your immigration status is. If you come in bleeding, they need to stop you from bleeding out. Mm-hmm. The federal government reimburses hospitals through Medicaid for that care in partnership with states. It's now ratcheting down the amount, the match, basically, that it provides to states like Oregon for certain populations. So that's a cut as well. Yeah. The other thing, though, is that this $421 million hole, that's just a moment-in-time representation. That is just a 2-year funding hole. Yep. There is a much larger loss of federal funding that's taking place here. So in the long run, over about 10 years, it's about $9 billion of money that would have been spent on medical claims in the state of Oregon that's not going to get spent.
Right. Yeah, we are not going to fill all that hole. It's a lot less money flowing into that healthcare system. One thing you noted in the recent story you did this week, Amelia, which was very good in laying all this out, is that Oregon stands to be hit probably harder than a lot of other states because of these changes to HR 1. Help us understand why that is.
Well, the other thing that's driven the cost growth in Oregon's Medicaid program is that we have added a lot of populations to Medicaid who weren't previously covered. So, and I think that's, a reflection of the fact that Oregon's had Democratic leadership for a long time. It's been a big policy goal. So Oregon provided Medicaid through the Affordable Care Act to single adults. Oregon has expanded Medicaid primarily using state dollars to cover undocumented immigrants and children who don't have legal status in the country. We've also we've created something called a basic health program for people who make just a little bit too much to qualify for traditional Medicaid. So if there has been a way to get federal dollars to expand this program to cover more people, Oregon's gone for it. Yep. And this bill targets kind of the exact funding mechanisms that states used to do that. And so, we were one of the most heavily dependent on federal funding of any of the states in this country.
Well, and as you pointed out, we have a 3% uninsured rate in this country. That is, very, very good. I mean, it seems pretty good, and it was not that long ago. We were at 15% or something in 2011, I think you reported.
Absolutely. It's been, I think, part of this bigger goal of, can we push towards something that looks like universal health care in this state?
That's the basic problem we're facing. For months now, I know this because I sit not too far from you. You have been tracking this group of experts, this round table, I don't know what you want to call it, that Governor Tina Kotek convened to try to sketch out a path forward, get ahead of this problem. What was this group, and how long has it been working? How has it been working?
Yeah, so the group was convened in December. Last fall, I was really hearing from people all across healthcare a lot of fear and unease about, there's this existential threat coming to the state's Medicaid program and these goals of sort of driving down the uninsured rate. What are we going to do? We need a vision. And so Governor Kotek convened this group to try to figure out how to start sketching a path forward through not just this sort of immediate cut that's going to hit, but really these bigger changes. Mm-hmm. And she brought in Bruce Goldberg, who is one of the architects of Oregon's current Medicaid system and has been a sort of longtime policy wonk interested in how do you make the healthcare system better, change the incentives so that we're making people healthier instead of just spending more money on their care. And they pulled together 18 people who are, mostly CEO level direct stakeholders in the Medicaid system, some labor representatives, a doctor, a dentist, the head of OHA. And the group's been meeting in private over the last 6 months. I tried and failed to get access to their meetings. I would understand all of this much better if I'd been able to sit in on the conversations. But I have been following their progress through repeated records requests for all of their notes, all of their slide decks, kind of the written work they've done.
Yep. Okay, we are going to take a break here. When we get back, though, we are going to talk about what possible solutions this group came up with. Okay, we're back. As we teased ahead of the break, this group of experts just this week offered up some findings about what Oregon might do to help close this $420 million gap you've been talking about, Amelia. Did it find any miracle solutions? Are we out of the woods?
No. Yeah. So this group was given actually a pretty challenging assignment, which was essentially find a way to cut $420 million from the state's Medicaid spending without kicking more people out of the program and without cutting long-term services and supports for people with disabilities. And they looked at a lot of different ways to find savings. They did, I think, hit on some good and interesting ideas that are worth pursuing. But in the end, they weren't able to achieve consensus on a single recommended way to do this. And so their report, which came out this week, offers the governor 46 different options. It's sort of a choose your own unpleasant adventure in Medicaid cuts. And one of the things that's just striking is that most of those options are going to save the state $2 million, $10 million, maybe $20 or $30 million at the high end. They are, it's going to be a very hard path to combine these ideas they've come up with to get to $420 million.
Yeah, I mean, and I think our listeners can tell at this point, anytime you get into the nitty gritty of healthcare policy, things get very complex. Can you help us understand broad strokes? What are the kinds of strategies folks are looking for to help save money?
Oh, yes. This is this is the good stuff. Okay, so I think you can start with cutting administrative spending. Can you cut spending on costs that aren't medical care or things that happen in a doctor's office? Then there's cutting optional benefits. So there's a pretty specific set of required benefits that all states have to provide, federally required. There's a lot of things that aren't on that list that Oregon does. Some of them you'd be pretty shocked by, I think. So, for example, prescription drugs are an optional benefit.
Wow.
Prosthetics are an optional benefit. Massage therapy, acupuncture, naturopathic care, those are all things that Oregon provides, totally optional. The big one in the optional benefits category is adult dental care. That's really, of the optional benefits, the only one that we spend a meaningful amount of money on. You could save, sort of ballpark $90 million by cutting all adult dental care.
Wow.
But the group was really skeptical that would actually be savings, because some of those people are going to turn up in the emergency department with an abscessed tooth and still need to be cared for.
Right.
And that is the challenge. There's sort of a fundamental challenge you see in the cutting benefits strategy, which is that there are some benefits that you can cut, but that might have downstream costs.
Yep.
And the optional things that are easy to cut don't save you that much money.
Yeah, I mean, reading your story, you list out a bunch of these, and it's like 20 million here, 15 million there. And by the time you add it all up to the point you get to 420 million, that is a very meaningful, it feels like, cut to the suite of services we offer. There is obviously a lot here. And I think you noted this, but did this council offer any indication of where it thinks the governor, the legislature need to look first? What avenue should they pursue? I mean, have officials you've talked to offered any suggestions of what kind of changes are most likely? Do we know anything, basically, at this point about where they're going to look next year?
Yeah. I think I would flag a few things that I think we're highly likely to see. The first is changes in the way that prescription drugs are paid for. I think there's a lot of interest in that from the governor's staff. It's certainly reflected in this report. And basically, that is an area where there's just incredibly complex, messed up systems in healthcare. And the state might be able to save some money by switching to a single prescription drug list, like a single list of approved drugs. And where the savings come from doing that, it's not what you might think. It's that you can then negotiate better prices big discounts off list prices with drug makers by agreeing not to include their competitors' generic products on your list. So, the state could probably save $25 million, maybe more, by doing that. There would be some impacts for patients. So they estimated about 90% of the drugs Medicaid currently pays for would be included on a list like that. 10%, you suddenly have a patient who's going to need to go through a prior authorization process or who's going to be told their drug's not covered. So I think that's one thing that there's a lot of interest in from the governor and her staff. I think when you look at the numbers, they need to find some way to save money on administrative costs or some other broad systemic changes like that in order to really make up this difference. And then the final thing that I really heard was one surprising, I think, finding from all this work is that the state spends a lot of money on substance use disorder treatment and on mental illness, long-term psychiatric care, psychiatric treatment, and really across the whole spectrum of services, both for people who are really profoundly ill and also on people who are maybe just getting talk therapy. And I think there's been a tremendous amount of interest in expanding those services, and now there's a lot of interest in how do we maybe dial that back? How do we make sure that the things that we're spending money on are really the right care? That actually, in some of the analyses that I've seen, that rises to the single greatest category of billing or spending in the program after, say, other spending that you can't break apart.
I mean, it's so interesting because in covering the legislature over the last decade almost, that has been a really big focus. How do we expand behavioral health care? And I think it's something you and I were talking about this, that probably the citizens of Oregon want us to be covering, given the very real challenges they are seeing every day sort of play out around them, right? We are seeing more and more unaddressed mental health issues, all sorts of those things that probably people would like us to be covering these things. But also, as you reported, Bruce Goldberg said, we've been adding to this budget for 10 years. Now we got to cut. You have to find some way to do it.
Yeah, absolutely. It's interesting because it was also an explicit priority of the governor,
right.
That spending. I think you can try to look within that spending and say, are there places where what we're doing doesn't make the most sense? So, just to throw out a few examples, the group has proposed reducing the payment rate for people doing talk therapy. That came from the fact that in some cases, Medicaid is paying higher than commercial rates for that care, which is pretty unusual. You can make an argument that this has been such an under-invested in area that was what it took to get enough providers doing the work. Mm-hmm. But you can also point to that as potentially wasteful spending. There's also questions about, are there in some of the nitty-gritty documents I've looked at, are we keeping people in more expensive, more complex care than they need to be because we don't have the next step down level of, we don't have a social worker who can check on them in their own home twice a week, and so they're in a residential treatment center when maybe that's more expensive than the social worker. But I don't think there's a straight, simple, easy way to unwind behavioral health spending without, potentially jeopardizing some of the gains that people want to see.
Yeah, I mean, when you talk about times of budget pain, one of the only upsides people will offer, because no one likes this, I mean, the politicians don't like this, it's a bad part of the job, is that it becomes easier to jettison the things that you don't need to be doing when you absolutely have to jettison something. And so if there is an upside to this conversation we're going to be having, it may be that we come with a leaner, meaner system. I think we should note, too, that one thing that makes this whole cutting in the healthcare arena especially challenging is that it's not the only place we are seeing contraction as a result of HR1, right?
Absolutely. Yeah. HR1 also shifts more of the cost of providing SNAP, the basic safety net food aid program, to the state. And so, you're talking about, and then when it comes to Medicaid, I think one of the really tough challenges that this group pointed out is that the Oregon Health Authority isn't just going to have to figure out how to implement these cuts.
Right.
They also have to stand up a whole eligibility system to verify and validate that people are meeting work requirements. That's something the agency hasn't done in the past. They also have to shift from doing eligibility checks on everybody in Medicaid from once every 2 years to annually or every 6 months in some cases. So it's a lot of change. And that actually is one reason the group proposed an alternative to all of these sort of more granular cuts that they proposed. You can either try to come up with a bunch of cuts that target the least important, most wasteful spending, or they said you could also just direct the Oregon Health Authority to do a 2 or 3 or 4% across the board budget cut that would then mean, a lower per person, per member, per year rate for Medicaid administrators, probably pay cuts for doctors, hospitals, clinics, everybody down the line that gets paid by those Medicaid administrators. But it would be simple, and it would be less work for the agency to administer, and it might be more predictable and more straightforward for all of the other people in the system as well.
But as you know, they were not pushing any specific thing, I think you called it a choose your own bad adventure. We're not going to put our thumbs on the scale, Governor, have fun figuring it out. And the rubber meets the road here, I guess. Early next year, the legislature is going to convene for a 6-month-long session. That's when they will be gutting out a 2-year budget and figuring out what it looks like. But Governor Kotek needs to put some proposals, something on paper sooner, right?
Yeah. So her budget is due, her proposed budget is due in December. And of course, these are all big, complex changes that I think the Oregon Health Authority will need some runway to figure out how to implement. So the clock is very much ticking here.
And meanwhile, as we often note on the podcast, there is an election this year. Kotek is running for re-election. So another thing for her to be focused on while all this very difficult stuff.
Yes. I mean, for Kotek, from a political perspective, she has cuts that she didn't, that she's not the architect of, but that she has to choose how to make.
Right.
That will affect constituencies that are important to her. And, the election's in November, the budget's due in December.
There's one more thing I think is just hard to ignore in this whole discussion, so we should just get it out there, Amelia. And that's the recent, I think, somewhat surprising announcement that OHA Director Sejal Hathi is stepping down very soon. Not something I expected to see in my inbox. I don't know if it was something that you were hearing about. I mean, what do we know about why she's doing that? And might the specter of having to just do this really terrible job of cutting people's health care be part of it?
I think it's a great question. We don't know very much. I have to be transparent about that. Hathi and the governor in their statements have said that this is essentially, a personal decision, that she's stepping away to have more time for her family, her health, and her priorities. And it's a situation where that could just be true. This is, to be the director of OHA is an 80-hour-a-week job on a good day.
Yeah.
And I think leading into a period of this much change and transformation is not a good day. And Hathi does have a young child and has written about the challenges of postpartum life. But I do also think it's interesting. She's been on this group. She's been serving on this advisory group, really steeped in the realities of the cuts they're going to have to make. And at the same time, her husband, and she's talked publicly about this, is now part of the ownership team for the Blazers,
right,
thrust into the middle of a big controversy over public funding for stadium renovations. So certainly the juxtaposition of those two things may have been challenging.
Well, and just to remind folks, we have approved $365 million for a Moda Center upgrade if things come into play. We are looking for $420 million to help healthcare. That's not a one-to-one thing, but it's
and As a budget nerd, I will make one important distinction that Moda Center money, that's one-time funding.
Right.
The $421 million is a perpetual, ongoing annual hole.
Right? And I don't even think we mentioned that the hole that lawmakers are looking at in the 29-31 budget, so 2 years from now, is double the one we're looking at here. I mean, talk about a difficult time to recruit a new OHA director. This is not a fun job to walk into.
Yes, that the questions only get tougher with time, and I think any of the proposals this group has come up with maybe delay the state having to make really difficult choices about how to run this program. But I don't think we're yet at a solution that puts the Oregon Health Plan on solid footing. Can I mention one more thing, Dirk?
Please.
That's just been on my mind this whole conversation. So I spent a lot of time reading documents for this work, for this story, and there is one document that I cannot get out of my head, and that is a comparison that some analysts did for this group that looked at, okay, what does the Oregon Health Plan spend money on that private insurance doesn't? They looked at, similar plans on the ACA marketplace that insures, a lot of adults. And the answer was really striking to me. So it's serious psychiatric care. That was one of the specific medical codes that, the state is spending money on that private insurers aren't. And then it was things like wheelchair van service, drugs for people with hemophilia or for children with muscular dystrophy, adult diapers. These are all like very specific areas where we spend a lot more money than comparable private insurance plans. And so it just left me with this picture of how much this is a social safety net program that is serving people who are often children. This is more than half the children in the state are on Medicaid, who are often quite sick or disabled.
It is not a hopeful setup for the discussions that we'll be covering over the next 6 months. And I am sure this is something we'll be talking about in future episodes of the podcast, hopefully with you, Amelia. Thanks so much for coming on today.
You're welcome, Dirk.
This episode of OPB Politics Now was recorded live in the Gert Boyle studio. It was produced by Andrew Thien, and our audio engineer is Layla Isbell. Our music comes from Audio Network. We'll be back next week with more political news from across the Pacific Northwest. Until then, you can find all of OPB's reporting, as always, at opb.org. Thanks for your support, and thanks for listening.